And good evening, everyone, and welcome to our lecture series at Boulder Community Health. I'm a cardiologist here, and today we're going to be talking about heart failure. I've given a lecture on congestive heart failure here several times, but this has some new data which I'm really excited to talk about because this is a fast and important changing field. Just a little bit about me. I was originally born and raised in Northern California. I did my undergraduate at UCLA in Los Angeles, and then I went to med school in Houston at Baylor College of Medicine. I came up here for my first stint in Colorado in the 90s and did my training at the medical school when it still used to be downtown Denver, and did my cardiology fellowship. I went down to Austin, Texas for about 15 years and ran a heart failure clinic there, and the mountains and lifestyle of Colorado lured me back here, and I was recruited and came back about 7 years ago and started the first congestive heart failure clinic in Boulder County, and now we have over 700 patients that we follow here. We're going to try to cover a lot in the next 45 minutes, and what I want to do is try to give you a definition of heart failure. When you get on the internet, there's a lot of different terms out there. I want to try to convince you that it's a very prevalent and economically costly and serious health issue in the United States. We're going to learn some of the signs and symptoms of heart failure, some of the leading causes of heart failure. If you suspect you might have heart failure or one of your loved ones, some of the tests that your doctors might do to either confirm or rule out it. We're going to briefly talk about medical therapy and then talk a little bit about sort of lifestyle changes and what a designated heart failure clinic like we have at Boulder Heart could offer you. So if you look in a textbook of cardiology, heart failure is basically when a clinical syndrome ensues when the heart is not able to pump enough blood to meet the metabolic needs of the body. Sounds sort of general, but we'll go into it a little bit. This is sort of a model of the heart, and when we talk about the main pumping chambers of the heart is divided into 4 chambers. The upper chambers are sort of receiving blood either from the venous or arterial system called the atrium or the atri, and the bottom chambers are the pumping chamber. But this red one right here, the left ventricle, when we really talk about the muscle function of the heart, is the chamber that we're talking about. Unfortunately, about 1 in 5 people will develop heart failure in their lifetime. There are about 5 million cases of symptomatic heart failure in the United States, and scarily, there's probably another 5 or 6 million people who have heart weakening that just don't have symptoms yet. And that's really important, as we'll talk about in this lecture. The earlier you can find out you have heart failure and get treatment started upstream before the disease is very end stage, it is a very treatable and long-term livable disease. There are about 500,000 cases of new heart failure a year, and despite all the advances from medicines to pacemakers to surgeries, probably 250,000 people still die a year of heart failure. It's a very costly disease, and that's mostly bad, but also good in that it has the attention of the government, of Medicare, of researchers, and a lot of research is being done with this. In 1998, the United States spent about $20 billion on heart failure treatments. In 2014, it was up to $32 billion, and it's estimated it will be about $72 billion by the end of this decade. It is the most costly heart disease in America. You can take heart attacks, stents, bypass surgeries, and put them all together, and treatment of heart failure is still more costly. And we'll talk a little bit, but if your heart really is weakened and it decompensates and you start to fill up with dangerous water in your lung, you get hospitalized with IV diuretics. And a typical hospitalization for decompensated heart failure is about 5 days and costs about $30,000 to $40,000. And this is just a slide sort of reiterating that the prevalence and number of heart failure cases is going up. And as you can see, in the 1950s, about 2 million people had heart failure, where it's estimated it will be about 7 or 8 million people later on this century. So what are some of the symptoms of heart failure? And a good acronym to remember is FACES. And these are some of the more common symptoms in somebody who has usually decompensated heart failure. So one is fatigue. The heart's not pumping out blood very well, so tiredness is one. Another is sort of goes along with activities limited, and they're just hard to get out and pump blood to the muscles to get out and do things. So somebody sort of pares back their activities. The heart a lot of times fills up with water as the lungs fill up with water as the heart is weakened. So shortness of breath and congestion in the lungs is something. When you start to get fluid buildup up in your body, another one is edema and your legs are swelling, and then we talked about shortness of breath. Unfortunately, some of these symptoms overlap with other diagnoses, and it's sometimes hard to figure out whether this is heart failure or something else. And many times we meet patients in the heart failure clinic who thought they had asthma or thought they had pneumonia or bronchitis, and they went through 2 or 3 antibiotic rounds and they weren't getting better until sort of their PCP or general cardiologist or lung doctor said, maybe this is something besides an infection in the lungs. And it really was water building up in the lungs with heart failure. Also, depression and tiredness, especially in the older population. It can come across thinking it's depression when really it is the heart's weak and they really are being withdrawn because they don't have energy for the activities. And again, it's very important to get through, and more depression, bronchitis, asthma are much more common diseases than heart failure. But if your treatments aren't working for those and you're continuing to have symptoms, it's important to think about heart failure, because the earlier you can diagnose it and get on treatment, the better we'll do. So what are some of the leading causes of heart failure in the United States? Well, the number 1 and 2 sort of go back and forth, but the number 1 is probably having had a heart attack and cholesterol blockages in your heart arteries. You're not getting enough blood flow to your heart. So coronary artery disease. The second is uncontrolled high blood pressure. And it's not having a blood pressure of 170 over 100 one time. It's sort of that person who goes to the dentist, they take their blood pressure and say, it's high, you need to see your PCP about it. And it's sort of forgotten, and you have sort of high blood pressure for 3, 4, 5 years, can eventually make the heart go into heart failure. The third one is what we call the double hit or idiopathic process. And what we think is that a virus attacks your body, but it also attacks your lungs, and it attacks your heart, and you genetically have a predisposition to it injuring your heart. So this is somebody that usually has some members in their family that developed heart failure mysteriously in their 30s or 40s, and then usually had a viral infection, and then about 6 to 8 weeks later, the infection and the virus doesn't go away, and they get very short of breath with swelling and things like that. When your valves don't work, either being stenotic or leaky, that can cause the heart muscle to weaken. And then lastly, alcohol we know is a toxin to the heart. If you're regularly drinking more than 2 glasses of alcohol a night, that can be a toxin to your heart and cause heart failure. This slide is sort of a busy and full of a lot of things, but these are the other 30, 40, 50 things that can cause heart failure. And one of the things that a good heart failure clinic and center will do is, if you don't have coronary artery disease, if you don't have hypertension, if the valves are not obviously a problem, that we need to look at the other things. And you can see other toxins besides alcohol can do that. Chemotherapy agents can sometimes do that. You need to use them to treat the cancer, but they can be toxic to the heart. Lead, cocaine, mercury, all are toxic to the heart. Metabolic things, the thyroid gland is very much tied to the heart, and if the thyroid's not working well, usually majorly not working well, either too hyper or too underactive, it can cause heart failure. And then a lot of different infections can do this. Down in South America, infections are the leading cause of heart failure. Non-infectious immunological things like lupus and rheumatoid arthritis can cause it. And then lastly, some genetic things where we know that the muscle is not working well, like muscular dystrophy, can all have those. So there's a lot of different things that can cause heart failure. What are some of the tests that we would do if you or a loved one you thought had heart failure? Well, one of the most simple and very cost-effective is an electrocardiogram, an EKG. Usually if your heart's not working well, it starts to thicken and get big, and we can see that pattern on an EKG. Also, a lot of times people can have had a silent heart attack that hurts the heart, and we can see signs of a heart attack on the EKG. And then lastly, just as the muscle is not working well, the electrical system of your heart starts to not work well, and we can see that on EKG. So one of the first things we would do would be an electrocardiogram. A lot of times it's important to get some labs. It's very important to make sure you're not anemic, that your kidney and your thyroid and your liver are working okay. A chest x-ray is helpful. As we talked about, if you have a heart that's not pumping well, you're very prone to fluid building up in the lungs. And on a chest x-ray, you'll see your heart enlarged, and you'll see patterns of water filling up in the lungs. The last two we're going to talk about in a little bit more detail in the next slides, but another one is an ultrasound, an echocardiogram, and then there's a blood test called a brain natriuretic peptide level, which we use a lot and is very helpful in the heart failure world. So an echocardiogram, and this is equipment that when a woman's pregnant, they can do an ultrasound of the developing baby. You can do an ultrasound of your gallbladder or kidneys. But we take a probe, it's about the size of my thumb, put a little gel on it, and we put it on your chest, and we bounce a sound wave about 5 or 6 inches down to your heart, and it comes back, and on this screen we can see the heart beating. It takes about 30 minutes to do a complete exam, but I think this is one of the most important tests to do if you think you have heart dysfunction. You can look at the strength of the heart, the size of the heart, the valves, and it's easy to do. It's an outpatient, no radiation or needles involved. A BNP level was developed about 20 years ago, and interestingly, it's called a brain natriuretic peptide level, but it has really little to do with the brain, and it's actually a peptide in the lining of your lungs, in the lining of your heart. And if the heart is not working well, it's either weakened or congested or stretched out, you release this protein into your bloodstream. So a good number to have would be a very low number where your heart is not releasing this protein. A higher number really suggests the heart is stressed. And this was developed as a blood test to be used in the emergency room when a person came in with shortness of breath to decide if it was heart failure or something else. There are a couple other things that can make your BNP level go up, which I put in here, such as having emphysema or having an acute pneumonia or acute blood clot in your lungs. As you get older, or if you have very advanced kidney dysfunction, you can raise the blood test. But really, a high BNP level is about 90% accurate for detecting heart failure, and a very low BNP level is about 98% certain that you don't have heart failure. So it's really, along with an echo and those other tests, an important thing that we do to look and see if your shortness of breath is coming from heart problems. More advanced testing would be a heart catheterization, where we go in and take pictures of your heart arteries, and if there's a blockage, try to fix them. Since we talked about the number one reason why people's heart gets weak is cholesterol blockages. An MRI of your heart is sometimes used, and that can really tell for some of the infiltrative or autoimmune process that can injure your heart. There's a definite pattern on MRIs. A stress test sort of leads to a heart cath, and again is looking for cholesterol blockages. And other labs we can do iron studies, mercury studies. And then genetic testing, which we do in about 20 to 30% of people to see if there's a gene or a genetic familial reason why the heart's weakened. So in heart failure, we sort of said it's when the heart's not strong enough to pump out blood to meet the metabolic needs of the body. But there's really, when you look and read about it on the internet, there's 2, maybe 3 different types of heart failure. And you'll see the term diastolic heart failure and systolic heart failure, and then sort of this mixed one. And that basically is your heart muscle, that left ventricle which I showed you. On each heartbeat, a person who has no heart problems usually pumps around 50 to 70% of the blood out of the chamber out into the body. So that's normal. Nobody's heart empties 100% of the blood. If the left ventricle can't pump out more than 40% of the blood on each heartbeat, that's called systolic heart failure. There are, and we're going to go into it a little bit, when your heart looks normal in strength but it's not working well, and that's called diastolic heart failure. And then when your heart is a little bit of both, that's called mixed. It's important because there's a slightly different prognosis and the medicines we use are a little bit different. Diastolic heart failure is when the heart is actually strong and pumping, but it's thickened and not relaxing. So on each heartbeat, you need sort of a second for it to relax and fill up with blood and then to be able to pump it out. And a person who has diastolic heart failure, the heart has gotten stiff and it doesn't relax well and doesn't pump blood well and it backs up. As you can see from this, it's very common in somebody who has long-standing high blood pressure or an arrhythmia called atrial fibrillation, though not all people that have atrial fibrillation have heart failure. An infiltrating process where your heart's being sort of replaced normal heart muscle tissue with an infiltrating protein are things like amyloidosis. And then coronary artery disease causes this, along with, unfortunately, just getting older. Your heart gets stiffer as you get older. In the past, there wasn't really any clear medicines besides getting the blood pressure under control and stuff, but we're going to talk about some of these medicines. And again, this is a talk where we're not going to dive too deep into the medicines, but in diastolic heart failure, there's a lot of exciting recent studies about SGLT2 inhibitors and ARNI agents and mineralocorticoid antagonists. Treating the underlying cause is one of the best ways to treat this heart failure. You get the problem under control, the heart failure gets under control. And this is a very common type of heart failure in people as they get older. As we talked about, the heart, as you age, the heart gets a little stiffer. And this is just a slide, and I think everybody can access these on the internet, is showing that there's really about 15 to 20 different things that can cause diastolic heart failure. Probably the most common being high blood pressure, atrial fibrillation, aging, and coronary artery disease. I want to just talk about the classification system we have for heart failure. The New York Heart Association heart failure classification was developed in the 60s and 70s, and a low number, 1, is the best, a high number, 4, is the worst. So it helps when you're reading literature to find out what type of, how symptomatic a heart failure patient was being studied, but it also helps a lot with prognosis and medications that we pick. So a class 1 heart failure patient is, we have some test that objectively shows that heart failure is going on, usually an echo showing the heart not working well. But they really don't have any symptoms. You can ask, can you climb up to the top of a 14er? And they say, yeah, and I don't get short of breath. Class 2 is a person who has an objective test showing some heart problems, and they can get short of breath or mildly symptomatic with really moderate to heavy exertion. So they go, yeah, when I hike 4 miles, I start to really get winded. Class 3 is symptoms with very minimal exertion, and it's usually walking less than 2 blocks. If you're short of breath walking less than 2 blocks, that's a class 3. And the class 4, the most serious, most dangerous, is somebody who's short of breath at rest. They're sitting talking to you, and they have to take sort of a breath in between each sentence. They've developed a newer heart failure classification called ABCD, and they did that because they found that there are certain diseases that you are very, very at high risk of developing heart failure. And the data would show, even starting to get on some of the most basic medicines to treat heart failure, even though you're not symptomatic. So the class A, for example, is somebody who has hypertension, but the echo doesn't show heart weakening yet. Or even diabetes, we know, is a big risk factor for developing heart failure. Class B is sort of the equivalent of the old New York Heart Association 2. Class C is the 3, and Class D would be the worst, and that's the very end stage symptomatic at rest. Why do I belabor that? Because we have some data that talks about where we can tell where what's your risk of being hospitalized or dying based on how symptomatic you are. And even that person who's A or a 1, as you can see from the slide, that person, even on medicines feeling great, has about a 2 to 5% chance per dying per year and about a 1 in 200 chance of being hospitalized. If you look at the Class C person, and in my clinic you come to the lobby and then you walk down a hallway which is about 150 feet to the room. Some of my patients can't make it down that hallway without stopping. That's a Class 3 patient. And those people, as you can see, have about a 20% chance of dying per year and about a 1 to 2 times hospitalizations per year. And then that person who's really short of breath at rest, that you can't get any better, probably has about a 25 to 40% chance of dying in the next year. So it's something that when you're diagnosed with heart failure, you got to really work with the team, get on medications, don't say, I'll come back and see you in 2 years. It's something we need to really get you on the best medicine treatments quickly, because this is a very serious problem. In the sort of ongoing pandemic of COVID, we know that a heart failure patient has a much more risky time if they get COVID. When the early came out, there was about a 1% chance of mortality in the early strains of COVID for somebody who really had no health problems. If you have heart failure, the early data was about 10% died. And that's just you have an organ that doesn't have a lot of reserve, and then you get this very significant respiratory and vascular infection with COVID. So it's something to really make sure our heart failure patients are getting immunized and their boosters. So that's the bad news, and we're about at a halfway point, and usually everybody's going, wow, this has been a really bummer of a lecture. But the reason I really got interested in heart failure and run a heart failure program is there's been so much advances. And this has really changed from a fatal disease to a disease that you can live with chronically and ski and be there for the grandkids and really live quite an active life. Before 1990, if you got heart failure, and this is a lot of times when people Google sort of survival and heart failure, old studies and statistics before 1990 come up. And really, we could treat you with diuretics, like Lasix to get rid of the fluid in the lungs. We could give you digoxin, which is made from a plant and has been around for 100 years. And actually, morphine is a very good drug to treat fluid in your lungs. It sort of makes the fluid go into the lymphatic systems and gets out to your kidneys. But besides those three things, we could treat symptoms, but we couldn't get the heart stronger. And if you look from studies before 1990, somebody with heart failure had about the same prognosis as somebody with metastatic breast or lung cancer in 3 to 5 years. But starting about 1990, we learned that what the heart, especially in those people who have heart failure with their heart pumping less than 40%, is they activate 3 or 4 hormones, which sort of try to keep that heart working well. But it's sort of like whipping an injured horse to keep running. Eventually, the horse just doesn't like that. And one of the things we found is, and that they developed, was medicines that can block these hormone surges. And with that, the heart has some time to relax and recover and actually can stabilize. And your heart is a wonderful organ. It can actually regenerate and get stronger again. So really, some of the key points in heart failure history and development of medicine started in the late 80s, early 90s, when we started to find these medicines that block these hormone surges that were very deleterious to the heart. And this is just a slide showing that, myocardial is sort of another word for heart. But if you have something that injures the heart, whether a heart attack or uncontrolled high blood pressure or a virus or a leaky valve or drinking too much alcohol, you actually turn on in your body these hormones in this box here. And one of them is your adrenaline system. We can draw a vial of blood from a heart failure patient, and their adrenaline level is about 8 times as high as somebody who doesn't have heart dysfunction. But also there's other hormones besides the adrenaline system. There's one called the renin-angiotensin system, which mostly comes from your kidneys and adrenal glands and the lining of your blood vessels. And then endothelial and pro-inflammatory leukocytokines all are activated when your heart is injured. And the breakthroughs in heart failure have been medicines that block this surge. Because you can see what happens if you don't block this hormone surge. Cells start to die. They start to change their DNA and become very unhealthy, not contracting well heart. And they start to shrivel up. So what really the key is to block those hormones and their deleterious effects. So I want to just give some abbreviations since I don't want the slides to be too wordy going forward. But BB stands for beta blocker medicines, which these are medicines that block a beta receptor in your heart and decrease adrenaline levels. And the ones that are approved for the FDA for treating heart failure are long-acting toprolol, Coreg, carvedilol, and Bistolic. SGLT2 inhibitors are one of the new people on the block, really coming out in the last year or two. And interestingly, it's a medication that blocks an SGLT2 receptor in your kidneys and blocks the reabsorption of sugar. So it was actually developed as a diabetes drug and still used as a diabetes drug, but it has been found a very potent, helpful drug in treating people with heart failure, even if you don't have diabetes. ARNI stands for an angiotensin receptor blockers, it's angiotensin neprilysin receptor blockers, and it blocks that renin-angiotensin system. It's a cousin of ACE inhibitors and angiotensin receptor blockers. And then MRA stands for mineral corticoid antagonist, and the medicine spironolactone helps and is also blocking the hormones. So why do I bring you through all these complicated medicines? Because now the recommendations from the world experts on treating heart failure is if you have a heart that's pumping less than 40%, you really need to be on all 4 classes of these drugs because you have so many different patterns and fingers of hormones that are activated, hurting the heart, that you need to block that. Unfortunately, there's not one medicine that all of these are combined in, sort of a magic silver bullet. And so one of the things is it's hard for a patient to, one, find out they have heart failure, which is a very serious problem, and then find out they're going to take 4 medicines. But if you look at this, and in this slide, the second column talks about the risk reduction if you take these medicines, which is basically the percentage chance that you'll help not dying. And so, for example, if you take an ACE inhibitor or an angiotensin receptor blocker or an ARNI agent, you drop your risk of dying by about 15%. If you take a beta blocker, 34%. Beta blockers are really, really important in heart failure. Mineral receptor antagonists, 30%. The SGLT2 inhibitors, 17%. So we have a lot of things, and these have been studied in placebo studies where people took a sugar pill versus the study drug, and really the people in the study drug did not die from heart failure as much. So to go into those medicines again, and this is in systolic heart failure, beta blockers block that adrenaline surge that's in the body. And actually when they do that, the heart stops weakening and actually starts to get stronger. The ACE inhibitors and the ARBs, which stands for angiotensin receptor blockers, block the renin-angiotensin hormone system that's coming from the kidneys and adrenal glands, and actually can slow down and help the heart get stronger. So, and I'm not a neurologist, but I think when you break your spinal cord, unfortunately, your nerves in your spine can't really grow back that much. The heart is a wonderful organ that can grow back. And people are a little surprised about that. And they say, my heart was pumping 20% on the echo. You're telling me if I take these medicines, my heart could be pumping 45% 6 months later? And the answer is yes, majority of times, yes. And then those SGLT inhibitors that came out, we're still learning more about how they work. It was sort of finding the tail before the dog. We found these really worked in people with heart failure, and they weren't that dangerous. They're not dangerous. And we think there's probably about 4 to 6 different mechanisms how they're helping the heart get better. This just is the World Society from the American Heart Association, the American College of Cardiology, and the Heart Failure Society all got together, and these are the leading experts in heart failure. And when they really talked about how to treat somebody whose heart is pumping less than 45%, you can see in the first column, step 1, you put them on all of those 4 classes of drugs we're talking about. The rest of the stuff is a little bit deeper than I want to go to in this lecture. The other thing, and I think this is a little tout for the heart failure clinic, is it's not only getting on the right medicines, but it's getting on the right dose. And this is a study on carvedilol, one of the beta blockers. When it was first developed, they knew it was safe in people, that it didn't cause dangerous things to happen, and it worked in the heart. This was a dose study, and you can see it was done back in 1996, so it's now almost 30 years ago. And if you take a 6 milligram tablet, your heart function went up some, but if you took a 12 and then a 25, that it went up incrementally based on the dose. So one of the things is to get on the right medicines, but all of these medicines, most of them are dose dependent, meaning the more of it you take, the better, up to a certain point, and there's definitely target doses you should be on. So to just get put on those 4 medicines and then that's it is not the right approach. You're about halfway there. Then you need to get on the right dose of the medicines. This slide has been in for about a year. When we first started having COVID, they realized that the COVID virus, one of the ways it got into cells was it attached to the receptors that are sort of working with ACE inhibitors and angiotensin receptor blockers. And there was a concern that if you took these medicines that block the receptor, you might increase your risk of COVID. And the answer is no. When they looked at this and they took some people and they had them stop these medicines that are really helping the heart, they didn't get COVID less, and if anything, their heart started to get weaker and more decompensated. So they found that this isn't true, and that in our pandemic of COVID, even though we're on sort of different variants than we were at the beginning, though it's a theoretical risk, it's not a true risk, and you should stay on these medicines and not stop them. Some other medicines that don't block the hormone surge, so we're sort of going back to medicines again we used early on. They relieve symptoms, but they don't stop the heart from getting weaker or get stronger, as the diuretics. These are medicines that work at your kidneys and help you urinate out free water and salt. They control sort of symptoms of congestion like shortness of breath and swelling in your legs. And the examples that we would use, the generic name is, or the scientific name is furosemide, the brand name is Lasix, another one is called torsemide or Demodex. And then digoxin, though it was probably one of the most important medicines we used 25, 30 years ago, now we use it probably only on about 10 to 20% of heart failure patients, and that's usually if they have atrial fibrillation, and we're using it just as much for atrial fibrillation. Hydralazine Iserdil is an important medicine. It's been found to work in the African American black population in particular, and we use that a lot in that one. In diastolic heart failure, I didn't have a slide a year ago. It was diuretics, treat the blood pressure. Now I think there really are some medicines that you could challenge your doctors if you have diastolic heart failure to say, I think I want to be on these, try these. And one is the SGLT2 inhibitor seems to be helping with diastolic heart failure. And then the ARNI agents and the MRAs and the ARBs all have been shown to be helpful in diastolic heart failure. I get asked a lot about supplements in heart failure, and unfortunately, they haven't been found to be that helpful. The ones that I do think are helpful are omega-3 fatty acids, especially if you've been found to have atherosclerosis and a heart attack. There's some data that it helps there, and also in some data in sort of vascular dementia. Coenzyme Q10 is helpful to mitigate the side effects and toxicities of statins. A multivitamin has been found to be helpful. And iron if you're anemic. If you're not anemic, iron has not been really shown to be helpful. But otherwise, the rest of the supplements have been studied, and at best are sort of neutral, and at times are harmful. And when you saw that, when you have now heart failure, your cardiologist is going to probably put you on 4 to 7 medicines. Those 4 medicines to block that hormone surge, plus a diuretic. You're all of a sudden on a lot of medicines, and when you start to add supplements on top of that, you can have a lot of drug-drug interactions, which we just don't know what's going on. Just as the muscle function can be damaged, the electrical system can be damaged. And many people with congestive heart failure and heart weakening actually have to have a pacemaker or a pacemaker with defibrillator function put on. And so, for example, if your electrical system is getting really slow and you can't get your heart rate up, or it's starting to have pauses for 5 seconds, we'll put a pacemaker in for that. And then we have something called biventricular pacemakers, and usually you'll see on your EKG the QRS is very slurred, which tells us that the right ventricle and left ventricle are no longer beating in sync with each other. And you want them to be in sync. And a biventricular pacer brings back the synchronicity of the 2 lower chambers beating in sync. And then lastly, we know that if we can give you all these great medicines that have been developed in the last 24 years, but if your heart can't get pumping above 35%, you have a real risk of dangerous arrhythmias originating from the bottom of the heart called ventricular arrhythmias. And we recommend a lot of times to put a defibrillator in, which is part of a pacemaker, and it basically has the ability to shock your heart or pace your heart out of dangerous ventricular arrhythmias. So not 100%, but I would say somewhere between 40 or 50% of our patients in the heart failure clinic have some type of pacemaker or defibrillator device. Just a little history on some of these. I'd say that about 90% of people that we see in the heart failure clinic, we can stabilize and they can have a very good functioning life on medications. About 10% of the people, the heart continues to weaken. And one of the things that we can do is put a mechanical heart in. We don't do that here in Boulder. We would send you down to the medical school at Anschutz. But now there are pumps that we can put in that basically take over the function of your heart, and they're small enough that they could be in your palm. And then for certain people at the right age with not a lot of other medical problems or cancer and are compliant with medicines with a good social support, a heart transplant for that 10% of people that are just not turning around and the heart's continuing to get weaker. The first organ transplant was a kidney transplant in 1947. Colorado was famous because we did the first liver transplant here in the 1960s. The first heart transplant was done in South Africa by Dr. Bernard in 1967. And about a month later, the first heart transplant was done out in Stanford, California by Dr. Shumway. In the beginning, they were not that successful. People didn't live that long. But a real breakthrough was in the 1981, they developed cyclosporin, which really made people keep their heart and not reject. And now we're doing, not here in Boulder, but in the country, about 3,000 to 5,000 heart transplants a year. And the survival is quite good. So mechanical heart and heart transplants are sort of last line agents, but a safety net for certain people. So to finish up for maybe the last 5-10 minutes, I want to talk a little bit about lifestyle changes, because you can take all the right medicines that have been developed for heart failure and still feel horrible if you're not doing lifestyle modifications. And one thing that a heart failure clinic does is we really take some time to sit down and emphasize some of these lifestyle modifications and sort of co-manage with our patients. For example, one thing, a heart failure patient's normal blood pressure is very different than you or me who doesn't have any heart dysfunction. I would say a normal blood pressure for somebody walking off the street, we'd like their top number to be about 110 to 140 and their bottom number about 50 to 80. In a heart failure patient, that would be actually hypertensive, too much for the heart. A normal top blood pressure is about 95 over 50. And we know from studies you're perfusing your vital organs with that. So it's learning not just the patients, but sometimes the nurses in the hospital that, oh yes, Mr. X heart is only pumping at 20%. 90/45 is a good blood pressure for him. We need to talk about fluid and salt restrictions. If you go out and have 5 glasses of iced tea for lunch, it goes into your stomach, gets absorbed by your veins, goes up to the heart and has to get pumped out. You've got an organ that really is having a hard time keeping sort of the metabolic milieu of water and salt. So a really salty meal, a lot of fast food, or drinking unlimited amounts of water can put somebody all of a sudden into flash water buildup in their lungs. So we talk about low salt diets, trying to not eat out at fast foods a lot, because your weight can go up 5 pounds with a pizza. We talk a little bit about the pathophysiology, like we did tonight in the earlier slides, about what happens when your heart's weakened. Because once they understand that sort of activation of hormones, they understand why they need to take 5 medicines rather than 1. And it really gets them to buy into the treatment. So we talk a little bit about pathophysiology. Unfortunately, non-steroidals, which are a great pain medicine, are really dangerous in heart failure patients, and I'm going to talk about that a little more. So we talk about avoiding daily non-steroidals. Alcohol, we talked about, can be a toxin, and I have 1 or 2 patients a year who get really disappointed and angry at me and say, you know, Dr. Blois, I'm taking all your medicines, I'm doing everything, but my heart isn't getting stronger on the echo. What's going on? And I say, you're still having 4 glasses of wine a night. And so the heart, you have to sort of cut back to off the alcohol when you have heart failure. We talk a lot about stroke prevention. The heart isn't pumping as well, and the blood can be a little viscous and prone to strokes. And then we talk about prevention of anemia. Anemia with heart failure is a bad combination. We stress immunizations, not getting obese, or if you're obese, losing weight, and then coming to a heart failure clinic. And just talking a little bit about immunizations. So we're now have been dealing with the pandemic with a COVID virus for over 2 years, but even before that, pneumococcal pneumonia and influenza was really dangerous, especially during the winter months for heart failure patients. When you got these respiratory illnesses, the heart just, what would normally be sort of a 2 to 3 day respiratory illness for somebody else, turned into a life-threatening illness for heart failure patients. So the recommendations were to strongly keep up with your immunizations for pneumococcus and influenza each year. The pneumococcus probably every 5 to 10 years. And this would go the same with the COVID, keeping up with your COVID vaccination and boosters. You just don't want to get these concurrent infections, which then can be a really deadly insult to a person whose heart doesn't have a lot of reserve. And this just is a slide showing that sort of the blips in hospitalizations for both men and women went up for the months of November through March, sort of our peak respiratory flu season. So really important to vaccinate. Obesity is a risk factor to developing heart failure. It's usually diastolic heart failure, but we know from the Framingham study, which was this big epidemiology population study in Massachusetts looking at people, that for men, for every 1% you're over your recommended BMI, you raise your risk of heart failure by about 5%. And for women, every 1% over their recommended BMI, you raise it by about 7%. So moderate to morbid obesity really is a big risk factor for developing heart failure. People say, doctor, the only way I can take care of my knee arthritis or my hip arthritis or my back problems is non-steroidals. Well, I have to tell them the data and we try to negotiate. We know that non-steroidals are very potent vasodilators and vasoconstrictors. So they constrict the blood vessels to the heart, they constrict the blood vessels to the kidneys, and you've already got a heart and kidneys that aren't working very well. And when they looked at people, and over 7,000 people who took non-steroidals on a daily basis in the BOLD thing, they had about a 10% chance of, a tenfold chance of dying compared to people who didn't take that. Now, that's somebody who took it daily. If you say, my back goes out once every 3 months, and I need to take it for 4 or 5 days, that's a little bit different. I try to get them off of them as soon as I can. But I really, if I see somebody is on ibuprofen or Aleve daily, I try to work with their internist or the rheumatologist to get them on something besides the class of non-steroidal drugs, because those drugs are just so hard on the kidneys and onto the heart. Salt and water restrictions. The weakened heart really has a hard time pumping blood and salt through the heart out to the kidneys and urinated out of the body. A lot of these deleterious hormones that are activated in the heart cause actually water and salt retention. So you're fighting against a mechanism in there. So we actually recommend to our heart failure patients only about 64 ounces of total fluid in a day. That's about 8-ounce glasses, but that's your cup of coffee in your morning, your milk with your cereal, your waters. And some people, it's very hard. Other people, they can get used to that. And then trying to keep their salt intake less than 1,800 millimoles. We talk about smoking and alcohol. Smoking, if you've had a heart attack and the heart attack's damaged the heart, one of the worst things you can do is keep smoking. The chance of you clogging up your arteries after that goes up about 8 times if you continue to smoke. So we really talk about smoking cessation. And then for all the reasons we've already talked about alcohol, it can be a toxin to the heart. People ask if exercise is okay in heart failure, and the answer is yes. It's actually been studied, and if you do moderate exercise, about 30 minutes, 3 or 4 times a week, those people have less chance of being hospitalized with heart failure or dying. So exercise is safe. So I'm going to finish in the last couple slides so I leave some time for questions and answers. But I want to give a plug to heart failure referral clinics, whether it be ours or somewhere else. When they've studied, people who have heart failure and go to a heart failure clinic live longer, are less chance of being hospitalized, and have a much better chance of being on the right medicines compared to not. That doesn't mean that you can't be treated by your PCP or general cardiologist for heart failure, but sometimes even a one-time consult to a heart failure clinic to say, yeah, I agree with everything that's being done, I have nothing else to add, or maybe have something else to add and talk with your referring doctor about that. But we get you on the best heart failure medicines at the right doses. It's more cost effective. And we really do a lot of teaching. I think an educated patient is so important to taking their meds correctly, to lifestyle changes. And we spend a lot of time educating you on heart failure and all those lifestyle modifications I talked about. Future breakthrough, there's a lot of genetic testing going on. There's something called precision medicine, where we're starting to see maybe your DNA not only likes a beta blocker, but it likes a certain type of beta blocker. Stem cell replacement is a hope that we could inject sort of a new muscle into your heart and grow it. And then mechanical hearts have come a long way. So I guess to summarize, I want to try to really say that heart failure is when the heart is not strong enough to pump blood to keep the metabolic needs of the body going. Unfortunately, it's really common. When we used to still have live audiences here, there would be 100 people in the audience, and I'd say, unfortunately, 20 of us are going to develop heart failure, 1 in 5. The symptoms are oftentimes many and vague. Shortness of breath, swelling in the body, and fatigue are the most common. And an echocardiogram is the most important test to evaluate and confirm heart failure. It's not the irreversible disease it used to be. Since the 1990s, many medicines and pacemakers have been developed that can help make heart failure really a chronic, tolerable disease where the heart muscle can get stronger and regenerate. Early detection. Don't live in fear of heart failure, but also don't put your head in the sand. The more you can detect it earlier and get on medicines, the better the prognosis. And then if one has heart failure, there are lifestyle modifications, exercise, salt and water restrictions, adherence to, unfortunately, polypharmacy medicines, stop smoking and keep up with your vaccinations. And then if you happen to be lucky enough to have a heart failure clinic in your county, going to one, even if it's a one-time consult or being co-managed by them or managed by them, really has the best results. Thank you for attention and good night. I think that leaves us about 10 minutes before we have to sign off, but Wendy, do we have any questions?
We do. Thank you, Dr. Blois. That was a great presentation. We've had several come in, and I imagine we'll have a few more questions come in the time we have left. So one of the first questions that was asked is that are vision issues ever a symptom of heart failure?
So in general, no. If you have vision problems, I would think of a lot of other things besides heart failure. We do have vision problems on some of the medicines we give. These are medicines that we're using, as we talked about, to block the hormone surge, but they're also medicines that your doctors might prescribe as an antihypertensive. And if we lower the blood pressure too much, it can cause vision problems. But in general, vision is not a common heart failure problem.
Thank you. You know, when I look up heart failure on the internet, I find a lot of scary information. Is there any hope?
Yes. The question is, you can get on the internet, especially if you find studies before or statistics before 1990. It is as scary as having metastatic breast or lung cancer. That is very old, archaic data. If you don't go see a doctor, then I think that data is still real. But now, one of the reasons I lecture to the audiences and run a heart failure clinic and take care of heart failure patients, it is a disease, unfortunately, where people can die from, but it's actually a very treatable disease, and I have patients that are going to be doing the Boulder in a couple weeks with heart failure. So the prognosis is very good, and there's a lot of positive things going on in heart failure.
What about daily aspirin? What about taking an aspirin daily?
So a lot of people might have seen Wall Street Journal articles or New York Times, but our thinking on aspirin is changing some. We used to prescribe it to a lot of people, including to prevent strokes and heart attacks from people who haven't had it. The recommendation now is if you've had a stroke, a non-hemorrhagic stroke, meaning embolic stroke, you've had a stent, a heart stent, or you've had a bypass surgery, those people should stay on aspirin unless there's real bleeding problems. The rest of the people, some of the risks of bleeding could outweigh that and ought to talk to their doctors. So we're pairing people off of their aspirin a lot. But if you've had a stent, a bypass, or an embolic stroke, you ought to stay on your aspirin.
Thank you. So regarding symptoms, say someone is really out of shape. They're trying to get in shape, and they get winded doing just moderate exercise. Is this necessarily an indication of the beginning of heart failure? Should you get checked out for this? How do you know when it's time to say it's not just because I'm out of shape, that I'm getting so winded?
It's a good question, and the question is sort of if you're out of shape, deconditioned, and you really can't walk a block or two because you're so out of shape. Usually somebody like that, when you start to exercise, you will quickly get in shape, quickly being a couple weeks to a month. If you're putting in the time and starting to exercise and you're not getting any better and you're still short of breath, then that's where I think going to your doctor and saying, I thought this was all being out of shape, but I've been exercising and I'm still not getting better. And that's when I think the EKG, the BNP level on a blood test, and a chest x-ray and echo are some of the things we can do on that patient who's not getting better. But I think at the beginning, try to exercise, get in shape, give yourself 1 to 3 weeks, and if you're not getting better, then that could be something.
Thank you. So again, how prevalent is the connection of heart failure to long COVID?
To what?
To long COVID.
The question is heart failure and sort of long COVID syndrome. And when COVID first came out, there was some good MRI studies looking at, and COVID really started mostly as a pulmonary lung problem, and then the inflammation that happens from it, vascular. But if you really do some sophisticated science looking at the heart, about 30 to 40% of the people can find evidence that it injures the heart. Now, does that mean that it lasts forever? No. I don't think we have really an answer yet. I can't tell you 5%, 10%, 15% for long COVID syndrome, but in general, it's very rare. Your practice,
do you only treat heart failure patients or also regular heart patients?
So I'm a general cardiologist also. I take care of people with cholesterol problems who have had a heart attack, who have atrial fibrillation, who have high blood pressure, or just really want to be proactive and preventative cardiology. So I would say probably 60% of my practice is heart failure and 40% is general cardiology, but I enjoy and take general cardiology patients.
Great. Please elaborate on the association between anemia and heart failure.
So the question is anemia and heart failure, and there's been a lot of population analysis, and you can sort of take people in a registry and see if they have heart failure and they have anemia, that they do the worst, or that's a really bad combination. The hypothesis of why it happens, one is when you're anemic, don't have a lot of red blood cells bringing blood around the body, and we talked about one of the main reasons why heart failure can occur is if you've got blockages in your heart arteries, and then if you're not transporting good oxygen from anemia, that can be a risk. It probably also makes the heart work harder, and then when the heart works harder, you activate other hormones. There's a lot of different mechanisms to hypothesize. We mostly just know that it's not a good combination to have, so we really, if we have a patient with anemia, we work with their internist, their hematologist, trying to correct and normalize their blood counts.
A guest here had chemotherapy 30 years ago. Does that mean an increased risk for heart failure?
So it all depends on what chemo agent was given. There's some that really have very little chance of cardiac toxicity. There's other that do. So it all really depends on which chemotherapy. And then the way to really check it is probably if you're concerned that you were exposed to a cardiotoxic chemo agent. And the oncologists are very good about this up front, and then also following for heart problems. An echo is probably the best way to see if it hurts your heart.
Does avoiding NSAIDs mean you need to avoid the topical gels as well as the pills?
So that's a good question. The question is, non-steroidals come in many different forms. Most of them are in a pill, but there's a topical gel. In general, the topical gel is not as absorbed as much as the pills. So if you had to use an NSAID on a daily basis, I would try to do the gel. But in general, the recommendations are to avoid NSAIDs. But I think daily gel, I do have patients of mine on that, and it's the only thing that could give them relief.
Right. This guest is speaking of Voltaren.
Yes.
Specifically.
Mm-hmm.
So what are the side effects of the 4 medications that you say you take for heart failure?
So that's a little bit of a longer talk, but the question is, all of these medicines, do they have side effects? And the answer is yes. Probably the most common is lowering of your blood pressure, so dizziness. But some of them can cause a cough. Some of them can interact with your potassium and kidney function. Usually helps them, but can hurt them. So a lot of times we'll do blood tests to check and make sure the potassium level and kidney function are okay. But I would say low blood pressure with dizziness is the most common. Otherwise, these drugs, many of them have minimal side effects. And the good news, have been around now, some of them since the early 90s, and some people have been on them for 30 years, and there's not late cancers or dangerous side effects occurring after you've taken these drugs for years and years and years.
Here's another one related to the 4 medications. Is there a test to refine the type of medication to take for heart failure rather than taking all 4 of them?
Unfortunately, no. We don't have that silver bullet, so it really is a multiple medicine regimen. which is sad, but it's also much better than we were 30 years ago.
Right. So we have about 4 more questions, and that's probably about the time we have left. If anyone out in the audience has another question or two, go ahead and type that in. But this is an interesting question. Do most pacemakers have a defib function?
No, most pacemakers are just straight pacemakers that help pace the heart. The defibrillator is when it's added onto it that it can cause the shock, and I would say that's the rare one, maybe only 10 to 20% of pacemakers. Most pacemakers do not have a defibrillator.
I'm going to head your way and ask these last couple questions. I have exercise fatigue, again with this, 6 years after a lot of chemotherapy. Is the echocardiogram best test to eliminate that it's heart failure?
I would say in that person who's had chemo, has had chronic shortness of breath and fatigue, an echo and a BNP level would be the 2 things I would order, along with your basic to make sure you're not anemic and your kidneys are doing well. But I do think an echo and a serum brain natriuretic peptide level would be good in that case.
We always ask if does most insurance cover the cost of these tests and treatments typically?
Yes.
Excellent. This guest asked, when taking, and I'm going to try to pronounce this right, it's spironolactone to reduce aldosterone, does it hurt a normal heart?
No, actually, the spironolactone is in the class of drugs that we call the MRA antagonists. And it's a very mild diuretic, doesn't make you stay next to the bathroom all morning long. And the main side effects with it are actually, it can cause breast swelling in about 1 in 20 people. So we have to stop that if the breasts are swelling, even in men. And then we have to follow your potassium closely. But otherwise, it's a very good drug, and as you could see, had about a 40% reduction in mortality if you took it. So it's one of the medicines we use a lot in systolic heart failure.
And is there any correlation between heart failure and altitude? Not attitude, altitude.
No, I would say our incidence of heart failure here is very similar to down at sea level.
Great. I think we have one more. How does low thyroid impact heart condition?
So your thyroid is releasing thyroid medicines which act very similar to adrenaline. And so if you are overactive, you can have sort of this very hyper catecholamine that can make the heart work harder, can cause arrhythmias, can make the heart burn out. On the flip side, your heart does need a certain amount of thyroid medicine to keep it in its normal sort of metabolism. So either high or low, the thyroid is very attached to the heart.
Thank you. So, thank you everyone for attending our lecture tonight and listening in. We've come to the end of our time. A recording of tonight's lecture is available at bch.org/livestream. You'll receive a post-lecture survey by email. Please take a minute to fill this evaluation out and the survey out for us. And again, please visit bch.org for information, latest information on the COVID-19 vaccine. So thank you again, Dr. Blois. Very great presentation. We appreciate your time and expertise. And thank you all for joining us tonight. Have a nice evening.